Otorhinolaryngologic surgery, second part of this chapter. We're going to talk about some nasal procedures. The nose is a facial feature and is our organ for the sense of smell. It is prone to many types of pathological conditions in the nose and the sinuses. So as we look at the anatomy of our nose, the external part is just the outer skin, which covers all those features of the nose. The tip is called the apex. Base with the openings are the nares. The internal chamber is lined with mucous membranes. There are pathologies that develop on the mucous membranes themselves. The nasal cavity is divided into two chambers by the nasal septum. Each cavity has a series of four bony projections called turbinates, or conchi is the other name for them. They're long, narrow, curled, shelf-like bones that protrude into the breathing passage of the nose, and when the septum gets deviated, they can cause obstruction of the passageway of air. There are four paranasal sinuses, and they are named by their location. The frontal sinuses are located within the frontal bone behind the eyebrows. They can be connected and be one sinus, or they can be divided. They are the most superior of all the sinuses, meaning they're up at the top up here. The ethmoid sinuses are a bunch of little sinuses that are behind the bridge of the nose, right between the eyes. The sphenoid sinus is small when you're first born and really doesn't develop until after puberty, and it can get fairly large. It can reach all the way back to your occipital bone in the back of your head. The maxillary sinuses are on the sides, lateral to the nasal cavity. They're quite large. So there are your paranasal sinuses, and you can see where they're placed and why they are named what they are. Some nasal anatomy, you can see that sphenoid sinus way in the back. You can see where the septal cartilage is and the nasal bone, and the maxilla gives you a pretty good reference point, as well as the palatine bone, which makes up the hard part of your palate. Olfaction, fancy name for your sense of smell. Rhinitis and sinusitis can be caused by allergies, they can be caused by viral conditions, and they can be caused by bacterial infections, as well as neoplasms that grow there. Nasal polyps grow out of the mucous membranes and are usually caused by rhinitis or repetitive rhinitis, often of an allergic type. Hypertrophied turbinates, those are those shell-like bones that stick out in your nose. When they become big and obstruct your passageway of air, we need to do something about that. And that's from chronic rhinitis, which usually is allergic in nature. Deviated septum can push those turbinates around and can also be caused by trauma. It also, with aging, tends to slip to one side or the other and change the way air moves through your nose. A septal perforation can be caused by any type of cancer up there, or chronic infections, too much picking of your nose, chemical substances, and drug abuse up in the nose. Epistaxis, as I said before, is a fancy name for a nosebleed. Some considerations of the nose. Some of these diagnostic procedures and tests are kind of common sense. Direct vision. Obviously, you might need a light to see up into the nose. Sometimes they'll take that otoscope that they look in the ear and they'll stick it in your nary and look up your nose and see what's going on up there. A mirror can help you see the back part, and with a little light bouncing off the mirror, you can see the turbinates and the posterior end of that vomer bone. Radiography is X-ray. and you can show fractures and occluded sinuses from bones that are blocking those sinuses. Different types of views are listed there. CT scan we've talked about way too much. Angiography, we're just looking at how the blood flows through the vessels that supply that area. Anesthesia may or may not be present. Sometimes these can be done under local anesthetics. Generally, the more complicated the procedure, the more involved the anesthesia provider is going to be. And sometimes you can use a combination of a couple kinds of local anesthetic and have an anesthesia provider give some light sedation. There are procedures where we're going to need a general anesthetic to accomplish. You may have a donut or headrest with a roll underneath the scapula to kind of tilt the head back, and that sort of hyperextends the neck. It gives you a little bit of hyperextension. Routine equipment, headlamps of course, ESU of course, power drills. ESU is suction, and bipolar cautery for kind of those fine bleeders. Some of the instruments are listed there. Make sure you wear eyewear and make sure the patient has eyewear. There sometimes is quite a bit of debris flying around, and you don't want things getting into the patient's eyes, and you don't want their eyes drying out during the procedure. Some anesthesia providers will tape them shut. Sometimes you will put ointment or drops into them. Some of the nasal instrumentation, this is available in your laboratory also. Ballinger swivel knife and the Knight nasal scissors. Takahashi is that kind of narrow cupped rongeur that is used in many procedures. Jansen Middleton septum forceps, we're going to fix the nasal septum with that. Septoplasty and a submucous resection, we use that quite a bit to bite out chunks of that overgrown septum or deviated septum. Some more instrumentation that's used for nasal procedures. These are quite common for submucous resection and septoplasties. Some supplies, we're going to need some medicine cups, syringes, needles, packing strips. The nose is often packed with a packing material which is really a big long strip of gauze that they'll pack up in there. Sometimes it has betadine impregnation on it, which means it has iodine in it, and sometimes it's just plain packing. And they'll pack that, just keep packing it up into there until they get everything settled in. And that holds the mucous membranes down after the repair. Usually a bayonet forceps is what they use for that. May use some drugs in addition to your local anesthetic to help provide hemostasis. Epinephrine, shrink the nasal mucosa and minimize pain. Often cocaine-soaked small sponges, either 2x2s or even in the packing, they'll soak some cocaine into the packing for post-op pain. Submucous resection, we're going to incise underneath that mucus layer, and we're going to remove and fix the bone that's underneath there that's causing problems. Sometimes we're straightening it out. Sometimes we're removing bone that has been fractured. Sometimes we are fixing a perforation in the septum from trauma or from cocaine abuse or other situations that may have perforated your septum. Position is supine. Anesthesia for those can be done local or general. Often, like I said, it's a combination, and when you're done, make sure you dispose of the cocaine properly according to your institution. Usually it's 2 people witnessing the disposal of it, and one's going to have to be an RN. Surgical procedure, you may use an extra stand. This is quite common in nasal procedures to have two setups, and one is usually for the anesthetic. The surgeon will often come in the room and want to have the anesthetic all ready to go, and he'll start with that, and that's usually on a separate Mayo stand than the rest of your instrumentation. Turbinectomies, there's three different approaches listed on the bottom of the slide: an inferior, a microdebrider, or a laser. Those are the three ways to get rid of those turbinates. Remember, this is from chronic rhinitis, and the inflammation has come over and over and over again, and these turbinates enlarge and get inflamed, and we need to get them out of there to stop that situation. Nasal polyps develop from allergic rhinitis. So people that have bad allergies, you get these polyps up in there, and there's some pictures coming up that'll show you what they kind of look like, and we got to get those polyps out. Like I said, it's from allergic rhinitis, and the swelling, they start as small little sac-like structures, and they keep growing and growing, and they look like they're these kind of decent sized fluid-filled sacs that are hanging off the mucous membrane. They may use a snare and wires to get them, or a microdebrider to get them off of there, and they might even mash them up into small pieces, which we remember is called morcellation, so that we can remove them that way. That's what they look like in the sinus cavities, growing off the mucous membranes. And usually they don't have much fluid in them. They look like they do, but they don't. There's the snare for snaring them off. Sometimes they can recur if you don't get them out nicely. FESS is endoscopic sinus surgery. That's where we're going to use video tower and a bunch of different scopes. We have shavers and some different angles on the lenses. These types of things, the equipment is going to be different probably in all the institutions, and it depends on surgeon preference. Some of them are going to have their own little toys or tweaks to this stuff, but that's sort of the basic list right there. But it is endoscopic surgery of the nose. Make sure you're familiar with the system at your institution. And if you do, like I've said in lab, if you get comfortable using certain systems, make sure you jot that down somewhere so that when it comes time for your resume, you can brag about how you know how to use certain systems. Institutions and surgery centers are going to like the fact that you're comfortable with certain systems. Antrostomy will treat sinusitis and remove recurrent polyps. It's another way to get at those polyps. Antrostomy, we're opening into the maxillary sinus through the wall of the maxilla just below the inferior turbinate. So we're going to make this incision up in there and go after those polyps. We don't fix the defect when we're done. It's packed, and then it ends up healing back over. It's a mucous membrane, so it's going to heal off and seal. If they can't get good exposure, they're going to do a Caldwell-Luke procedure, which is, I have a picture coming up. It's a different approach that comes over the canine teeth to get back up into that maxillary sinus. And there's a Caldwell-Luke retractor for lifting up like that. So that incision is going to come over there and come right across above those teeth. We don't do these in pediatric patients that haven't had their permanent teeth come down yet, for obvious reasons, because we're going to impede the progress of that happening. So you have to have your permanent teeth in before you can use this approach. Little artery clip applicator that we use for a Caldwell-Luke can be quite a vascular area and bleed quite a bit, so we have to be ready to provide adequate hemostasis. The upper ear digestive tract has some salivary glands, and there are 3 pairs in there. The parotid glands are the bigger ones, and there's an excretory duct called Steno's duct in there. If that duct gets blocked, we need to take that gland out because it's just not going to function, and it's just going to be problematic. And as the slide shows, there's two types of cells in salivary glands, mucus and serous. The serous are the ones that secrete a fluid with a digestive enzyme called amylase. That's where your digestion begins in your mouth. Of course, you're going to chew and break the food down with your teeth and your tongue, but the enzyme amylase is going to start breaking down the carbohydrates and the starch and the glycogen. Mucus will also help make a bolus out of what you're trying to swallow and help it go down your esophagus. The pharynx is commonly called your throat, averages about 5 inches in length, and it serves the respiratory tract by receiving air from your nose and mouth, and is a passageway for your food and fluids. So it's divided into the 3 regions listed on the slide. Your palatine tonsils are 2 oval masses that are made out of lymphoid tissue. Those are the lymphoid ones. The lingual tonsils they're also lymphoid, but they don't get nearly as large as the palatine tonsils do. When we talk about tonsils, tonsillectomy and adenoidectomy, we're talking about the palatine tonsils and the pharyngeal tonsils. The lingual tonsils are way at the back of your tongue and are quite hard to see, actually. You need a mirror to see them fairly well. The pharyngeal tonsils tend to kind of slowly atrophy and disappear over time as you age, but when we talk about adenoiditis, as I said, in adenoids, they're talking about those pharyngeal tonsils. Larynx is your voice box. There are 3 types of cartilages, or 3 pairs of cartilages that make this up. And of those cartilages, the only one that is elastic is the epiglottis cartilage. The others are hyaline cartilages. The largest and most superior, meaning the upper one of the cartilages, is the thyroid cartilage, and that's what makes up your Adam's apple. Trachea is your windpipe, located just anterior to the esophagus. Trachea joins the cricoid cartilage of the larynx to the main stem, leading to each lung. Remember, your main stem is your primary bronchi, and it breaks off and turns into your right main stem and left main stem bronchus, heading down to the lungs. There are cartilaginous rings that support the right and left main stem of the bronchi. The right main bronchus is just slightly longer than the left. The lungs, as the slide shows, are divided into lobes. Right has 3, left has 2. We've been over some of that. Remember, at the end of the bronchial tree are the alveolar sacs. That's where the gas exchange occurs. Your esophagus passes through the diaphragm at the level of the hiatus. Some of you have done some of these procedures where we're trying to fix where that esophagus passes through the hiatus. Often, the upper portion of the stomach ends up herniating up into the chest, and we need to somehow secure that, and that helps correct some of that acid reflux disease. When the upper part of the stomach herniates up into the chest, the acid from the stomach is going to slowly eat its way up that esophagus. There's not enough tightness there to hold it down below the diaphragm. Our mandible is our largest and strongest facial bone, and your temporomandibular joint is way out on the lateral side. It's way out here at the glenoid fossa of each temporal bone. And sometimes that joint can start to click and get stuck, and we have to do a repair and try to get that joint to stop locking up and clicking. Some of our neck anatomy, kind of a side view. If you cut the head in half, you can see all the different structures there. More neck anatomy, going a little lower and cutting in. You can see the epiglottis there. Sleep apnea affects about 18 million Americans. This data is a little bit old. It's probably quite a few more. There's a lot of undiagnosed sleep apnea in our country, and the problem with it is like I said in class, if we're not breathing well at night, we're not oxygenating, and we're not keeping our heart happy. You can end up with a nasty heart attack because you are hypoxic and you're starving your heart from getting the oxygen that it needs. Laryngitis, inflammation of the vocal cords, often caused by virus. The bad part of it is the edema in the larynx. It can make your voice really bad and sound like you swallowed something like a tennis ball. Things that irritate it are tobacco, of course, and any kind of smoke. Sometimes other chemicals give off fumes that can irritate the larynx. Breathing humidified air and getting away from the irritants is how you fix it. There can be some neoplasms in the larynx. Symptoms are going to include, again, voice issues, hoarseness of the voice. People who smoke are at a greater risk of developing cancers in this area, of course. Tracheitis and bronchitis, usually caused by a virus, can be also caused by irritants, breathing in fumes of something, especially tobacco smoke or other types of smoke. Same thing, remove the irritant, increase humidity. Esophagitis is an inflammation of the esophagus, and reflux of stomach acid into the esophagus can cause esophagitis and give you really bad heartburn. It can sometimes feel like someone's squeezing your chest, or can often be misinterpreted as a heart attack because of the pain in your chest. And a diverticulum is an outpouching of a wall of the intestinal tract. A Zenker's diverticulum occurs up here in the neck, and usually what we're going to do is staple that off. It's not a complicated procedure. It's usually pretty quick, and we're just going to get rid of that little outpouching in the esophagus. The symptoms that people have for this, they're having a real difficult time swallowing. They'll swallow something and it'll feel like it's caught there, and then they can't get it to go down. So we staple off that little diverticulum, food will go down the proper pathway. Pharyngitis can be viral or bacterial. Strep throat, that's your pharyngitis. Super contagious in its acute stage, especially when you first have a fever, extremely contagious. Transmitted by direct or indirect contact. Common cold can cause it. There are other infectious bugs you can get, mono, Staph aureus. There are many different types of bugs. Usually a culture swab down the throat, see what's growing, antibiotics. Tonsillitis, now we're going back to those palatine tonsils, sometimes the lingual tonsils, but it's usually the palatine tonsils, same ones we would remove for tonsillectomy. So they can be acute or chronic. Often they recur to the point where those tonsils have become so inflamed that we need to get those out of there. Polyps we talked about a little bit, and they can also occur down in your throat. You can get polyps, and especially on your vocal cords, things like that. You get a persistent hoarseness in your voice, and people that sing professionally or sing a lot can develop these nodules on their vocal cords, and also little granulomas. Those can be caused by abuse of those vocal cords and can often become infected. And because once they get inflamed, they become prone to infection. So we have to be careful with that. If you think about where that is in your throat, that's kind of a dangerous area to be getting infected. Same types of visualization to see down there. Headlamps, there's a gooseneck lamp, which is just what you think it would be, a lamp with a big long bendable neck. Flashlights, indirect visualization, like I said before, you can take a mirror and stick that back and you can see posterior a little bit. If you get the right angle, you can angle it down so you can see down in the throat. Cultures a lot to find out what the bugs are in the throat. Bug counts, we can, if we have an elevated white count, there's obviously an infection going on. Count over 10,000 indicates the presence of an infection. Some considerations, there's some different types of tests we can do for the air digestive tract. Radiology, of course, X-ray, CT, some MRIs we can do. Video stroboscopy is used for analysis of the tissue during your speech. So we're analyzing those vocal mucosal movements. Polysomnography is used to diagnose sleep apnea. This is where we're going to record body functions such as heart rate, respiration, how the air flows in and out, and your blood oxygen levels, because we want to know if you're saturating well. If you're not saturating well, you can risk injury to your brain and your heart. So very dangerous. Multiple sleep latency tests. This is a test to determine how long it takes you to fall asleep. Not a big fan of it myself, but the test says the average time is 10 to 20 minutes. You should be able to fall asleep. And if you're falling asleep in less than 5 minutes, you're considered to have some type of disorder. What that may be, I don't know. Narcolepsy, maybe. So remember, some of these procedures we do in the throat, the mouth gags, we're going to have the Davis and McIver mouth gags. Fisher tonsil knife is a knife that's used, it's kind of like it's an angled knife that they can use to shear off those tonsils, palatine tonsils. Number 12 knife blade is a lot like a Fisher. It's an angled blade like that. It's kind of a hook. Lucan's tubes we talked about before, collecting specimens. Glass slides are quite common if the specimens are small. And here's some more supplies and equipment that we may use. Tongue blades are used to help position the tongue out of the way often. Cotton tip applicators are just big long Q-tips, often have a wooden stick with a little ball of cotton on the end. All these types of positional supplies and aids depend on the patient's age and what procedure they're having and the type of anesthetic that they're having. And like I said before, some of these procedures you may use a couple different kinds of local anesthesia. You may use some light sedation. You may use general anesthesia and then use local at the end for postoperative pain control. There's some of the mouth gags, the Davis and the McIver. There's your Fisher tonsil knife. Looks kind of like a hockey stick. You can reach in and sort of scoop that tonsil out with a knife blade. Bronchoscopy is used for biopsy of the bronchi. It's also to look for any type of invasive lesions that are inside that bronchus and its tributaries. Laryngoscopy is used for difficult intubations and also for diagnosing and obtaining biopsies and removals of foreign bodies. If you swallow a penny or a rubber ball or something, you can use a laryngoscope and get down in there and see where it is to retrieve it. Also your vocal cord procedures. You can see pretty well down. You can see the vocal cords nicely with the laryngoscope. Bronchoscopy looks just like that. Sometimes they'll irrigate with it a little bit. It has ports that can irrigate and suction, and you can also feed biopsy forceps through it and take small biopsies out of the bronchi. There's your laryngoscope. You can see right down to the vocal cords. Very helpful in difficult intubations to be able to view the cords so you can pass the tube. As you can see right there, there are the true vocal cords, and to the sides are the false vocal cords. Tonsillectomy, adenoidectomy. You're going to see a lot of these probably in your clinical. We're going to do that turban head drape that we practiced in lab. Nowadays, most of the time, they use coblators. Some of the old guys still do it the old-fashioned way and cut them out with a Fisher knife and that sort of thing. Neck will be hyperextended. It'll be a general anesthetic usually. Can be quite bloody sometimes. So there you can see the palatine tonsil swollen and sticking out, and that's what we need to get out of there. That's not only painful, but it's obstructive. Parotidectomy, same type of thing. This time we're taking out the parotid is the, remember, the salivary gland. UPP is for sleep apnea. This is where we have all kinds of obstruction back there, and we need to clear out that airway so you can breathe better and be able to oxygenate. Usually if you're having this procedure done, your sleep apnea is really causing you not to oxygenate well at night. It's becoming dangerous. So you'll do a tonsillectomy and an adenoidectomy along with part of the palate stuff. So there's a big redundant uvula right there, and you can see the obstruction all in here. If this were all open, all that would take air in, but all this is being blocked by overgrowth. So once we take all that out, you can see nice open space. Goodbye sleep apnea. Laryngectomy is a complicated procedure. It's going to be also kind of a dangerous procedure. You have to have a trach tube available, and they'll put one in the patient, and you have to keep it in for a couple days. The reason is because when you operate on all that, it really swells up and you don't want to lose the airway. Then it becomes emergent. Radical neck dissection is a big, long, involved case, often combined with plastic surgery. These take all day. You're taking out lymph nodes, vessels, muscle. They're going to sometimes put grafts back in to fill the defects from everything they take out. And often they'll take the fibula out of the leg to recreate the mandible and make a new mandible. This is a big, nasty dissection usually done for an invasive tumor. TMJ arthroscopy. This is when you get that clicking, crunching in your jaw, and sometimes it can be very painful. So they'll take a scope, go in, and we'll try to free up that joint so it doesn't get caught and click. Tracheotomy is done for many reasons, as it says, and it's to protect the airway. So sometimes these are done quite emergently. They can be done out and for trauma in the field, motor vehicle accidents. They can be done in the emergency department, ICUs. They can be done in the middle of a surgical procedure when you're losing the airway, and you need to be able to recover that airway or it's over. General anesthesia is usually done. Once they dissect down to the trachea, they're going to make a little slit in the trachea and put hooks in there, and they're going to lift those hooks, and a spreader can be also placed in the incision. Often a wheat liner or something is put in, but the hooks go into that cartilage and they lift it up and pull and stick the tube in. This is when you don't want your cautery on. Anesthesia can be blowing flammable gases down the airway, And if you hit the cautery, like I said in class, ba-boom. That's about it for tonight. Study hard. Enjoy spring break. Thank you.